Hello and welcome to Single Payer Radio. I'm Paul Hoppe, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network. Our programs air every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud. The show is a project of Kentuckians for Single Payer Health Care in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe health care is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system that works for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Our station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, Doctors Mike Flynn and Jean Shively join me as co-hosts, and our topic is the law in Kentucky regarding women's reproductive rights and how it affects both the patients and the physicians. Mike has recruited a special guest to speak on the topic. Mike, I'll let you get it started.
This is Michael Flynn, a retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer. Any comments that I make represent my personal views. Do not represent the views of the Department of Surgery or the University of Louisville. Gene?
I'm Eugene Shively. I'm a retired general surgeon from Campbellsville, Kentucky. I worked at Taylor Regional Hospital in rural Kentucky. What I have to say on this program are those of mine and not the University of Louisville, the Department of Surgery, or those of Taylor Regional Hospital in Campbellsville, Kentucky.
We have a special program today, and we have a special guest who is willing to come on the program and share some of his thoughts about these issues. And I'll introduce him in just a moment. We're going to talk about the anti-abortion laws in Kentucky and perhaps even in some other states and how that affects the ability to practice medicine. Tom James is an internal medicine and pediatrician. He got his bachelor's at Duke, medical degree at UK, did internal medicine residency at Temple University and a pediatric residency at the Children's Hospital of Philadelphia. He has had a number of other positions, and I'm going to ask him to share some of his work background with our readers when I'm finished with the introduction and make a few other comments. He's currently working in the Family Health Center in Portland. Before I turn this over to Tom, I just want to advise our listeners to double check the facts and the comments that we make. There are a lot of resources out there dealing with these issues of these anti-abortion laws and the impact that it's had on the ability to practice medicine. The Journal of the American Medical Association, the New England Journal of Medicine, the American College of Obstetrics and Gynecology, Wikipedia, and a number of other organizations are resources that our listeners can use to kind of double check the comments that we're making. So Tom, we're going to give the floor to you to make the comments that you'd like to make for as long as you'd like to make them. And again, I would ask you to share with our listeners some of your clinical activities, and the floor is yours.
Well, thank you very much, and thank you for inviting me to be here. I wrote an article last year for Louisville Medicine, the journal of the local medical society here, because in my role working in the Family Health Center and my roles in the past working with various insurance companies, I've seen a wide range of issues related to the changes in the abortion laws in Kentucky and national. Just a few comments that I could make just to start things off is that number one, there's a trust relationship between physician and a woman. And it gets into areas of very sensitive, that are highly sensitive, and it's tailored to the individual. But when you start dealing with governmental regulations and laws, that becomes then a whole swath across, and individuality is lost for the sake of consistency. As everyone knows, the Dobbs versus Jackson ruling in 2022 led Kentucky with its trigger law to put into effect legislation that precludes abortion in Kentucky except to save the life of the mother. That particular definition is something that I have yet to find in my look through the medical literature and online search engines as to what constitutes that definition. I think we start also, thirdly, looking at the distinction between medical ethics, which is about human self-determinism, and the moral determinations of the sanctity of life. So we have polar opposite ethical points of view, and then the government jumps in on that. So the article was written to look at what is the physician's role. I'm a primary care doctor. From both the internal medicine point of view, I see patients, women who are pregnant and find themselves in a position where that is not tenable. As a pediatrician, I also see families that are overwhelmed with too many children, some of whom were not wanted originally. So that I started looking around from my clinical point of view and saying, what can I do to counsel women, given the fact that it's a misdemeanor to refer somebody in Kentucky, and it certainly is a felony to perform the abortion. So what role is there? And that's where I have found resources out of state or nationally that I could give to women and still be within the law. And that's where we're trying to go, is understand the bottom line is that this legislation and the interpretation of the Supreme Court has negatively impacted, in my opinion, the individuality of patient care. There is documented higher mortality now. There's discrimination as to who can achieve an abortion because of the barriers to care and the impact of aggregate costs. That's kind of my opening, and I think a lot of those could be explored.
Okay, Gene, you want to begin?
Yes, I've been very interested in what happens with complications of pregnancies, and where's the physician? What's their status? For example, as a rural general surgeon, I used to see patients with ruptured tubal ovarian pregnancies fairly frequently. And under the current law, what should a physician do if somebody comes in with a ruptured tubal pregnancy and they're bleeding? And then are they liable for taking care of this lady? And then the other scenario that's affected our OBGYN in Campbellsville is second trimester ruptured membranes. As you know, there's a high instance of sepsis in those patients, and the mother is at risk. What is the responsibility of the physician, and what are they supposed to do with these patients?
And that is million question. If we could break that out into those that are medical emergencies or surgical emergencies versus those where there's some time to get some thought process. If there's time, then the physician working with the ethics committee and the hospital legal staff can mount a case to say this woman's life is in danger, and that we have taken all reasonable steps to be able to preserve the life of the mother and the fetus. That's required by the law. If that condition can be met, that there are no viable options to preserve the life of the mother or the fetus, and with legal backing, then the pregnancy could be terminated. Those are difficult situations. Those are not common. More commonly are the ones that you described, which are truly surgical emergencies. And it does take having two physicians who are willing to testify if someone calls them on it, that there were no options. Individual physician decisions not sufficient. It takes at least two. And as you know, in Texas, there are written such that anybody can be empowered to be a whistleblower and call the state and say, this abortion should not have happened. We're not at that point, fortunately.
Well, there's an article in the November 14th edition of the Journal American Medical Association that addresses the impact of these laws in Texas. And it's really awful. One, the physician or the obstetricians are literally by law required to conduct medical malpractice when it comes to the complications of pregnancy, regardless of an abortion that is a request of a woman who doesn't want to have a child, but the ability to deal with the serious medical complications of pregnancy is forcing people to conduct medical malpractice based upon the standards of the College of Obstetrics and Gynecology. The maternal fetal mortality rates are higher in Texas than they are in this country, and this country's the impact is higher than they are in most other first world countries. This is really a crazy situation that we're living under. I guess the question is, where do we go from here? With the way the Congress is divided with the partisanship, I don't see anything changing this in the next 3 or 4 years.
No, and it's going to be speculation on my part. We do know, excuse me, that there was one woman who stepped forward to challenge the abortion laws. And she ended up, because of the time lag, having to go to Illinois.
Now that's in Texas.
No, one person
in Kentucky.
in Kentucky.
Okay.
What it probably will end up taking is some physician who feels strongly enough to do the right thing for the patient and not jeopardize medical ethics, even if that's in violation of the law, and have that tested in the courts. Would a jury of peers convict a physician who saved the life of a mother but lost the life of a fetus?
Well, the problem with that is that most physicians have great fear of malpractice and going to court, and there are very few physicians who have the finances and the time or the emotional fortitude to take on a case like that, and particularly if it's a criminal case and they risk even a criminal conviction.
And that has been the Damocles sword hanging over the head of all physicians who are taking care of women who are pregnant, and particularly those who may face having to make that decision.
What do you think about the issues of residency training, the future of that? Just talk about Kentucky. The College of Obstetrics and Gynecology requires that a resident have some training in the ability to conduct an abortion, mostly because of the ability to deal with the complications of pregnancy. And the information that I'm seeing indicates that there are fewer applications to residency programs in states, including Kentucky, that have these abortion laws. The practicing obstetricians are either thinking about retiring early or leaving the state. And they do surveys of residents applying for training programs, and they don't want to go to states that have these laws because they can't get trained and they don't want to practice there. And it looks to me like Kentucky is going to eventually turn into a maternity desert with all the issues that go on in rural hospitals in the absence of any physicians that'll carry out obstetrics. It's not gynecology is not an issue, but practicing obstetrics.
Kentucky Lantern, which is a nonprofit news organization, has reported that since the Dobbs decision, there's been a 15% drop in physicians in training applying to Kentucky programs in general, but in OBGYN, the decline is 23%.
Yeah.
So it's 23% for the nation, or
That's Kentucky.
Just Kentucky. There's a
Right.
decline of 23%.
Right. And it was published this past year by Kentucky Lantern.
Well, Gene, let me ask you then. You're out in rural Kentucky. It seems to me with hospitals closing, there are fewer and fewer mental health professionals, pediatrics, the way I understand it, and obstetricians available in the state to take care of pregnant women. And it looks to me like there's going to be even less. It's going to turn into a maternity desert like the state of Idaho.
Fortunately, the hospital I'm affiliated with, we're maintaining our pediatricians and our OBGYN right now. We were close to losing OB about 2 or 3 years ago, but we've recovered from that. We have had some problems, though, with the patients, particularly with ruptured membranes in the second trimester. I know of one patient that was sent all the way to Chicago for treatment, and the patient, they had to raise money to get her up to Chicago. She couldn't afford to travel that far. So it is a real problem, particularly in Appalachia, and I'm afraid it's going to get worse. And the situation with rural hospitals, if the new administration says they're going to do what they've said in the campaign, will get worse because they're talking about cutting back on Medicare, privatizing Medicare, and decreasing Medicaid. Most rural hospitals in Kentucky are struggling, but because we expanded Medicaid in Kentucky during the first Bashir administration, most of them have been able to get by. but more and more hospitals are affiliating with larger networks, and so far we're barely getting along. But we've had some hospitals to close, and I think we're going to have more problems with, particularly in OBGYN.
Now, Tom, you work in the family health clinic in Portland, is that right? Now,
I'll be there too.
Yeah. Now you're dealing with the underprivileged population. It seems to me, especially after Gene's telling us this poor woman has to go to Chicago, this is the group that's going to be most impacted by all these anti-abortion laws and the limitations to physicians to practice good obstetrics.
That certainly has been well documented that women who have more means are able to travel out of state, and those without means have much less. And this is what I put into my article, are several different organizations that can help in funding individuals. But it takes a lot of effort for somebody who's indigent to be able to track down the resources, to be able to get a necessary abortion in another state.
Let me bring up one other issue is that's been debated for quite a long time is the right of consciousness. The Catholic hospitals, ever since I can remember, have always been allowed not to do tubal ligations and vasectomies. Should a physician have a right, if he's doing OBGYN, not to do an abortion? And should a pharmacist have a right not to prescribe or hand out medicine to stimulate abortion, the morning after pills?
Well, you've just opened up a can of worms, because that gets into a lot of legal and moral issues and access to care issues. I wish I could answer it, but I can't answer that one.
Now, it's my understanding that in Texas, a physician who gives a patient advice about where to go to get an abortion, how to get there, or anything like that, they're liable for some sort of penalty. But in the state of Kentucky, that is not illegal. Is that correct? I'm not,
Correct.
familiar
this-
with the laws about that.
Yes, and that's the reason why I wrote the article
Yes.
in Local Medicine, is to be able to give physicians some of the information to be able to pass on to their patients.
And
By the way, one area that was not discussed with with the determination of whether a woman's life is in danger has to do with serious mental illness. People with significant psychiatric problems, behavioral health issues, who may be suicidal, would not qualify, even if that were to mean that there's a potential of loss of life.
now, I'm sorry, I don't understand exactly what that means.
Well, it
And I
means-
don't know whether our listeners do either.
Yeah. When the law says that an abortion can be performed to save the life of the mother and the fetus, the thought had to do with all the physical health issues. But as I think everybody knows, serious mental illness is a significant problem, not only in Kentucky, but around the country. And it's getting worse. And a woman whose mental health is going to be jeopardized and may even contemplate suicide would not qualify to have an abortion for those reasons. It has to be something which is cause an immediate physical loss of life, not one that could impend through psychiatric problems. Does that make any sense?
Yes, so you're saying if a patient comes in with severe depression and they're at suicide risk and they're pregnant, they do not qualify for a abortion because of their risk of suicide.
That's right. They would essentially have to be kept confined to the hospital until such time as either they are emotionally better or the woman delivers, and then decide who's going to take care of the baby.
That who does the woman?
Yeah.
Okay. Now, what about that? Brings up another issue. When I'm revealing my age now, but when I was a resident, we used to rotate through the old St. Joe's Hospital here in Louisville. That was before Roe versus Wade in 1974. In those days, somebody came in and was pregnant and didn't want to keep her baby. The nuns arranged for adoption. It was cheap. It was simple. And there seemed to be very little problems with that. Now, it's extremely complicated to adopt a baby and extremely expensive. What are your thoughts on that, and why can't we go back to situations like that?
And this would be speculation on my part, but from looking at the numbers of abortions, of unwanted pregnancies, and that's different than ones where a woman's life is in danger. That there's just not enough parents to adopt. Our foster system is already overwhelmed. So I just don't think that that's going to be a viable option at this point.
Tom, our listeners are not medical. You and Gene and I are all, and we understand kind of what we're talking about. For the benefit of the non-medical listeners, could you, I'm not sure how to put this, could you kind of give a brief kind of non-medical overview of what the actual Kentucky law, anti-abortion laws, explain that to our listeners in a way that they can understand what a physician can do, what a physician can't do, what their risks of punishment are, and what is the situation of the individual who is wanting to get an abortion not because of a complication of pregnancy, and how they can interact with a physician, and this can all be done without violating the limitations placed on them by these anti-abortion laws in Kentucky.
There's a revised statute that was adopted prior to the Dobbs decision that had a trigger in it so that if Roe v. Wade were overturned, this would go into effect, and so it did immediately.
Yes.
That particular law has several different components. If I can try to interpret the law, which is difficult for me, but let me try.
Well, that's one of the issues, isn't it? Is that the laws are difficult to understand.
It says that no person shall knowingly administer or prescribe or procure or sell to a pregnant woman any medicine or substance with the intent of causing a termination, which means then that the medication abortions, which have increased significantly since this, cannot be prescribed in Kentucky. This has been the issue in Texas, as you know, where their state attorney general is now suing out-of-state physicians who are prescribing the mifepristone for people in Texas. But in Kentucky, we can't even give medical abortion.
Now, wait a minute. Can you explain that? You're saying that the Attorney General in Texas is suing physicians in other states?
Yes, it was a woman in New York who's being
Right.
sued by him because she will write a prescription for the medications, and that is sent to the individuals in Texas.
Okay.
In just the way it would be like with telemedicine, where a physician out of state can prescribe an antibiotic for bronchitis. In this case, there are physicians in other states who care for women with abortions and are performing essentially a telemedicine and prescribing for those people in those other states where the doctors can't do it.
Now, they're doing that in Kentucky though. Out of state physicians
That's
are,
right.
are sending the medications to the individuals in Kentucky.
That's correct.
Yeah. Okay.
Now, is that legal or not legal, or do we know?
That's legal in Kentucky.
It's
It's just,
legal. Okay.
it's just in Kentucky, a Kentucky doctor cannot prescribe for the medications that would induce an abortion. And of course, that's only done early on in the pregnancy, not.
Right.
It
But
couldn't do that.
but an Indiana physician could prescribe that for a lady who lives in Louisville without any legal risk.
Correct.
Okay.
The law then goes on to talk in terms of the surgical abortions. Those are not legal in Kentucky except to save the life of the mother, and that's not defined in the statute. It does require that there be a second opinion before doing that to determine that the woman's life really is in danger, and that all measures to save the fetus's life and the mother's life, both, have been employed.
So how does that work when you have a woman who is, say, 8 or 10 weeks pregnant and has a miscarriage and ruptures her membranes? Because those are the issues. Because my understanding is that these laws are so imprecise that not only the physician doesn't know exactly what their limitations or their abilities to practice are, but the hospitals don't either. And you've got this double whammy of trying to figure out what to do in an environment where you're practicing, where they're also trying to figure out what's okay.
I agree. This is untested area, and we hear cases where a woman has been with a situation of a spontaneous miscarriage, but is bleeding, and until they get down to the point that she starts to lose her blood pressure, the physician's been worried about trying to stop the bleeding.
That is essentially medical malpractice.
Yeah.
Do you disagree with that?
No,
I mean, if you did something like that in a different situation, you could be sued. And the legislature, in their ideologic wisdom, have created an environment where obstetricians are virtually required to conduct medical malpractice in that situation.
And that's what happens with the creation of laws that are maybe well intended, based on your point of view, but the writers consider them to be well intended, but they don't know all the circumstances, so they cut a. And that's where case law comes into place. But as you pointed out, no physician wants to be put into the position of having to do that kind of a defense. So it creates a barrier to good medical judgment.
And you said that in the situation of saving a mother's life, they had to get a second opinion. Now, I assume that's a second opinion of another obstetrician, or is that a second opinion of a lawyer, or who
It would be another, it would be a medical
Yeah,
physician,
yeah.
not
Well,
a lawyer.
now, these risk management groups that hospitals have, that physicians often have to go to in order to determine whether they can do something like that or not. That's what are they? Are you familiar with them enough to tell us who makes up these risk management groups?
I've only been in one situation previously, several years ago, and it was unrelated to the topic we're discussing,
Yeah.
where we've had to bring in the risk management people and the ethics committee. They work together along with hospital lawyers to make a determination. That was in the case of somebody whose religious beliefs would not allow a transfusion. And that was the only way to save that person's life.
Yeah.
I want to bring up another issue. Is what are we allowed to do in the state of Kentucky if we have a patient with an unviable fetus? For example, if it's discovered on ultrasound that we have an anencephalic fetus, that for the listing group, that's a patient with no head that's not viable. Are physicians allowed to abort that fetus, or do they have to allow it to go all the way to delivery and then just let it die?
I've been in that situation with a child with anencephaly without a brain, that was not allowed to. The mother could not have an abortion. She had to carry it to term. That baby spent about 10 days of life before finally dying. It was an extremely sad situation. The mother just went through all kinds of emotional problems. Everyone taking care of that baby felt a lot of grief. But under the current laws, that she could not have an abortion because her life is not in danger.
And there are other situations like trisomy 18 and other situations where the fetus is not viable. We are in the same position, correct?
That's right.
You know, these are remarkable examples of the ideologic stupidity that exists in this country today and exists in the Kentucky legislature. It's really embarrassing, I think, to be a Kentuckian when you understand what the kinds of laws that they've passed that deal with these issues.
This also gets into the whole issue of infertility management, because typically several of the fertilized eggs are implanted where one may survive, but if there's several, then often there's a recommendation for selective reduction. That's the term. It means abortion of the ones that are too many for a woman to really deliver well. And that's going to have an impact on management of infertility.
So what's the status of in vitro fertilization in the state of Kentucky?
So that's not impacted by this law, but per se, but it does mean that the obstetrician is going to only try to do an implantation of one and not several.
Okay, well, what about those?
That's my understanding. Since I don't do this, I'm not going to. I could be corrected.
Do you know what happens to those eggs are still in frozen and still being preserved? What's going to happen to those? Do we
You know,
know?
no, I don't know. I know what happened in Cleveland when at the University of Cleveland, there was an electrical issue and the freezer where those eggs are stored it could not maintain its temperature. And there were a number of lawsuits related to that.
Wow. Do you think it's possible to have a compromise where you could have a law that you could do be against the law for a viable normal fetus, to make that against the law to do an abortion, but still have laws where we can take care of situations to save the life of the mother and to do abortions on fetuses that are incompatible with life?
I would hope that there would be some common sense that can be written into law. That's going to take a lot of lobbying to be able to do that.
Tom, we had Ernie and Ona Marshall on a while back, and we did a program. And one of the things that Ona talked about in the very beginning, and I'm asking you about this because I'm not quite sure exactly what's happened, but I think what she was wanting to happen happened. The way I understood it, some physicians challenged the anti-abortion laws, and the court, in its ideologic wisdom, decided that they didn't have the status to do that. It had to be done by a pregnant woman.
Right.
And she has put together, Ona had put together this arrangement between the ACLU and Planned Parenthood, and had a phone number. And it's my understanding that a woman has come forward. I'm asking you if you're familiar with this.
Yes.
And to chat. Could you explain that to us and our listeners so that they understand what's going on here? I think this is a very positive thing. I don't know where it's going to go, but I think our listeners would be interested in knowing the details of this.
Well, I can't give you all of the details. I know the basics.
Well, that's probably good enough.
As you said, the courts determined that physicians are not directly impacted, and therefore they did not have standing. That is, they could not bring the case before them. So there was an effort to find somebody, one woman who was pregnant, who was very brave, to step forward and say, this is something that is important to me. It's going to have impact to me. But by the time, and so she did have that case. Now, she got far enough along in the pregnancy without any legal action that she had to go out of state. So I don't know, though, whether that means that the courts would throw it out or whether they will continue, because she did have standing when she brought the case.
Yeah.
That I don't know.
Well, that's interesting. So I guess when does that decision get made? Or do you have a sense of how long this process all seems to drag on and on and on and on?
Yeah, the legal procedures do drag on. Pregnancies don't.
Yes.
They have a termination one with a baby. Or,
Well, Mike, you've had experience with the legal proceedings going on for, 15 years, right?
Yes, yeah. I'm not going to get into the details of that. It was finally just settled. Well, we're kind of getting toward the end of the lollipop here. Any other thoughts you've got about these issues, Tom? Maybe we might switch over for a little bit and talk about some, some of the generally, the health insurance issues. I'd like to get your views about some of the things that we were, that have sort of occurred in the national view about private health insurance companies following the assassination of this fellow in New York. But I want to give you an opportunity to make whatever final comments you'd like to make about these anti-abortion laws in Kentucky
Right.
and how that affects the ability. I mean, literally, the legislature has put itself in between a physician and a patient in a way that is just, in my opinion, a terrible infraction of justice.
There are penalties to a physician. It's a Class D felony if a physician does an abortion in Kentucky, with penalties of 1 to 5 years of imprisonment and a fine of $1,000 to $10,000. There's also a Class A misdemeanor if the abortion is done on a minor or done without the patient's consent. So you have additive misdemeanor and a felony crime that just way over any physician making a decision. On the other hand, for the patient, the issues of their ability to pay the emotional toll that this decision makes is not ever done lightly, in my experience. The costs that incur and that separation of doctor-patient relationship because of the way the laws are written.
I think of all of the times I spent in an office talking with a patient about, doing some sort of surgical procedure and going over the risks and the alternatives, sometimes having another individual in the room with me as well. And I just can't imagine having to try to figure out what you can do because the legislature have decided that, if you were doing a breast biopsy that, I don't know, you had to talk to them about something that it's just astonishing. Have you ever thought about how you would function practicing surgery in an emergency room? This affects emergency room physicians, the pediatricians, all kinds of people.
Yeah, it was already tough enough before
Yeah.
getting these laws, but I always try to go into great detail about the risk and of the surgery plus the benefit, and I always documented that. But this situation, like ruptured membranes in the second trimester, is just overwhelming.
Well,
You wonder, would these laws have come in place if men could become pregnant? This falls into the area of really gender bias in
Yeah.
the legal.
well, I don't know. I'd call it misogyny, but anyhow, it's. Well, listen. Let's we've got about maybe 10 minutes left. I would like to hear your thoughts, and I think our listeners would as well, about. They're the CEO of United Healthcare, and I'm not justifying that. I think that was a terrible thing to do. Was killed in New York, and what happened after that, I think, surprised. It certainly surprised me. It seems to have surprised everybody in the in the press that when I listen to CNN, MSNBC, and even Fox News, they're just scratching their heads, not understanding something that we've been talking about for 3 years here, was the impact of the for-profit health insurance companies on the quality of life of the American citizen. And apparently this guy, this assassin, is in some ways becoming a folk hero because he's generated a lot of anger and angst against the for-profit health insurance companies. I wonder, what your thoughts about that are. I was surprised about it. I'm certainly not. I wouldn't justify killing someone, but I think it certainly has brought out a lot of feelings in the American public that I think is important, especially with this new administration coming in, and they're talking about things like privatizing Medicare. So anyhow, I'd like to hear your thoughts about this. I know this isn't what we said we were going to talk about, but go for it.
This would be the content of a week-long panel discussion.
Well, we may get into that another time.
Very complex issues, and recognize that what creates an anger in other people creates delight in others. We have a very complex system that has been put together over time without any intent. But I think everybody is trying to do the right thing, but we're fighting a different cultural and economic system than so many other places in the world. What can we do collectively to ensure that everyone has appropriate health care and not excessive health care services?
Well, I would disagree with you about everybody's trying to do the right thing.
Okay.
The for-profit insurance companies, they've been around for a long time, but they really came alive in the 90s. And, the CEOs are getting paid 10, 12, 15, $30 million a year, depending upon what they could get away with. And they're just the top guy. And then you go down the ladder at the other ones. And then, when the Affordable Care Act was negotiated, the Medicare administrative cost is 3 or 4%? And these for-profit insurance companies were allowed, based on the negotiations, to take 20% for whatever, advertising, profit, investor dividends. It's a crazy system.
Well, I'll challenge you on that number. By law, it cannot take more than 15% for their administrative costs and profit.
Okay, well, 15, 20%, whatever, but it's a lot.
Right. And Medicare itself has had costs between 5 and 10% just to administer.
Yeah, okay.
So what do you think is the theoretical solution to our healthcare problem? If you were the czar of healthcare in America, I know it's politically probably not possible now, but what would you recommend that we can solve some of our problems and decrease our cost of healthcare and increase our results?
I'm going to have to go back to Thomas Jefferson. If all men were angels, there would be no need for government or for health policies.
All right, Tom, I think we're at the end of the lollipop here. I want to thank you again for coming on. I learned a lot from you, not only how much it costs, how much the for-profit insurance companies take out for profit, but also a lot about these anti-abortion laws. And I absolutely agree with you. The ability of an obstetrician to provide good care to a patient under in the laws of Kentucky is really a terrible situation, and it's going to impact the access to care because people are not coming into the state, they're leaving the state, and they can't even the ability to train obstetricians and gynecologists in the medical school is seriously affected. Gene, you want to make any last-minute comments before we close this?
Well, certainly the laws have to be clarified and changed, or we're headed for even more problems. And I have an opportunity in January to meet with my senator and representative, and we'll try to bring these issues up. Our senator has a very important position in the legislature right now. So hopefully we can talk to them, see if we can change some of them.
All right, Paul, you ready to take us out?
Okay, this wraps up another single payer radio program. I want to thank again Doctors Mike Flynn, Gene Shively, and Tom James for getting together today with me to present this meaningful topic. And I also want to thank our listeners for joining in. I hope you enjoyed the program as much as I did. And be sure to come back next time for Single Payer Radio. Have a wonderful day.